Hi, everyone. My name is Vincenzo Berghella. Once again, welcome to AJOG MFM Live. We're doing highlights again for the November issue, and I'm honored to have Mhatre with us again. Go ahead, Mo.
Hi, everyone. So nice to see all of you. Welcome back. For those of you who haven't joined us before, I'm Mhatre. I am a maternal fetal medicine attending at Tufts Medical Center, and I'm the director of the MFM Fellowship Program. What we wanted to show for you today, as usual, for those who aren't familiar with our format, we tried to select articles that will impact how you may counsel or manage pregnant patients. And we tried to select articles that have great study design and will be applicable not only to our MFM colleagues, but also to anyone who's caring for pregnant patients, whether that be OBGYN generalists, family medicine docs, nurse practitioners, midwives. And so we hope you enjoy it. We're going to be doing graphical abstracts, and I've created the majority of the abstracts, but we are using the author's graphical abstracts when they've been provided. Here is the list of the articles that we are going to be highlighting today, and you can feel free to look at them in detail on the AJOG MFM website. And with that, I'm going to hand it off to Dr. Berghella, and he can get us started.
Thank you. So the first trial we wanted to share is this one, comparing 6 versus 12 hours balloon catheter placement for induction of labor. It's a meta-analysis of randomized trials. They actually put 5 trials together, almost 1,000 patients, as you can see in the slide. And usually now, even at Jefferson, we use 12 hours. We keep the catheter 12 hours. If it comes out before, great. Otherwise, at 12 hours, we take it out. But there are, again, 5 trials looking at 6 hours earlier. And I guess somewhat surprisingly to you, but it does make some sense, is that if you actually plan to take it out at 6 hours, most of that ripening has happened already, and you end up having, as you can see on the left side, on the right side on the slide, shorter insertion to delivery time, but more than 4 hours, and actually, surprisingly, even a lower C-section rate, with no difference in Bishop score, removed delivery time, duration of oxytocin, or adverse outcome. So it is safe to take it out earlier, and it seems like you may save some time from insertion to delivery. So certainly something to consider. Mo?
The next study we wanted to highlight today is looking at the selective fetal reduction of uncomplicated dichorionic twins by parental request, comparing to expected management of ongoing twins and the pregnancy outcomes. And, this is an interesting question. Certainly it raises some ethical, considerations, but really how to counsel patients who are requesting this, and trying to evaluate the literature and see what we can determine might be some effects by having this elective fetal reduction. And that's what this group wanted to evaluate. So they performed a systematic review. They looked at 2 databases all the way up to December 2023. They were able to find 5 cohort studies. Understandably, there haven't been any RCTs in this particular question. And they performed this meta-analysis. Their primary outcome was to look at the prevalence of preterm birth. And then they also had some secondary outcomes in terms of the gestational age at delivery, the birth weight, and then trying to look at other adverse pregnancy outcomes like gestational diabetes, preeclampsia, and stillbirth. And what they found was that there was a decreased rate of preterm delivery, particularly at less than 37 weeks. That was of moderate quality of that evidence. What they did find is they did see some trends as well of a decreased incidence at other common markers of less than 34 weeks, less than 32 weeks. They did find lower incidences with elective fetal reduction for low birth weight, and then some studies also suggesting an improvement in the rates of adverse pregnancy outcomes. What the authors wanted to say and note is that a lot of these associations that they found, particularly in the secondary outcomes, was based on very limited data, and they thought that, based on the grade criteria, had low quality evidence. So they wanted us to interpret these associations with caution. And really what I think we need to be mindful of is that there should be some larger studies to evaluate this to really assess if there is a benefit that we need to make note of, but certainly something to keep in mind when patients bring this up as a potential that they're considering.
Thank you. One thing I want to highlight is that you're making some of these beautiful graphic abstracts. Some of the authors make them, but you make the ones that, they're not made by the authors. So I tell all the authors, please make these graphic abstracts. I think they're so helpful for kind of getting a snapshot of different papers. This one is on the association between perinatal depressive symptoms and child development from Emily Miller and secondary analysis of a randomized study. So good prospective data on over 200 patients in which eventually the neurological developmental testing of the children was followed to 5 years of age. So unusual to have such long follow-up. The antepartum screen for depression was positive 34% of the time, and the postpartum 15% of the time. Again, well done screening. And interestingly, and somewhat reassuringly, that's why I thought this was so important, that patient with depressive symptoms compared to those without had no worse outcome in terms of the child IQ at 5 years of age. There are many things, obviously, that can affect child IQ, genetics, environment, etc. But at least in this well-done prospective study, this was reassuring that depression was not associated, maternal depression was not associated with child IQ at 5 years of age.
Here we have one of our graphical abstracts from our authors. This was a study performed in China. This was an RCT evaluating the use of calcium in addition to oxytocin when inducing patients at term who have premature rupture of membranes. And the idea behind this is that we know that oxytocin, when it binds to receptors, it releases calcium, and that is essential for uterine myometrium contractility. And so the hypothesis is that giving additional calcium may have a synergistic effect and improve contractility and improve the success rate of induction for women who come in with PROM. So in this single center RCT, the patients over 210 per group were randomized to either have the regular infusion of oxytocin versus having the regular infusion as well as a bolus of 1 gram of calcium gluconate. And then they evaluated the rates of rates of vaginal delivery within 24 hours. That was their primary outcome. And they did find a statistically significant difference, and they found that the more patients who had the intervention delivered faster within 24 hours, had a faster time to delivery, and they did not see any change in C-section rate, tachysystole, fetal heart rate decels, and didn't seem to have any higher rates of adverse maternal or neonatal outcomes as well. So this could be helpful to consider for improving our rates of induction in women who present with term PROM.
Yeah, I think it's so important to have shorter and shorter, more efficient induction. The last paper we want to review is this one on what is the best mode of delivery in nulliparous singleton term vertex pregnancy. A pretty important, obviously, and still controversial issue. This paper put together other papers. It's kind of an expert opinion. You can see the other authors with me on the slide: Dr. Adewale, Rana, Bonani, Chaham, Belusi, Dwight Rouse, and John Barrett. Really, the evidence is that if you plan a C-section in these low-risk individuals, again, with their first pregnancy, singleton term vertex, you end up having, by systematic review of some randomized studies, possibly better neonatal outcomes, as you can see, less low pH, less complication, less parental death, obviously less chorea if you don't labor, and urinary incontinence for the women, but more wound infection and more of an issue with placenta accreta in the future if you do the C-section, versus if you plan a vaginal delivery, and most of the time these are successful, even in these randomized studies. Your recovery time is probably quicker. You have less wound infection, less secreta, with the issue that, again, the trials showed more pelvic floor disorders and more satisfaction with planned vaginal delivery, as many women, most women by far, want a vaginal delivery if possible. With that, we also find that a lot of people now delay their childbearing and actually desire only one or two babies. And so one of the thought of this paper is that perhaps we need a randomized study to compare planned vaginal delivery at 39 weeks versus planned kind of trial of labor and vaginal delivery at 39 weeks in this low-risk women, looking at perinatal morbidity and mortality, and also longer-term maternal morbidity and mortality, even looking eventually at pelvic floor disorders, depression score, satisfaction, bonding, and all kinds of stuff. We're putting together a large group of investigators. You're welcome to participate. But this is, I think, an interesting expert opinion paper worth reading and certainly worth discussing.
Wonderful.
Maybe, Mo, you can wrap it up.
All right. Well, thank you so much, everyone, for tuning in. We will be showing our December highlights soon, hopefully before the holiday break. So stay tuned for the dates for that. But thanks for joining in, and we'll see you then. Thanks.
Bye, everyone.